Good evening, everybody. It's a great pleasure to welcome Dr. Michael Harari from Tzfat to talk to us tonight. Michael has had a distinguished career both in Australia and in Israel as a paediatrician. The introduction to him was made partly, of course, by his appearance on the media in the UK talking about the Meiron episode. But in addition to that, we also had the advantage that Mervyn Jaswan, who's a member of the association and treasurer, has worked with him and is currently in Israel working and contributing to medical education in the field of paediatrics in the same department as Michael. And that commendation, really, I'm sure everybody here would agree that recommendation is probably a little bit better or in better standing than the recommendations from the BBC at the moment. But Michael, you've chosen the title Syria to Tzfat, then Meiron, and this indicates the fact that, of course, the hospital in Tzfat has been at the fulcrum of really several events in the last 10 years, and we're delighted that you've taken your time to prepare a talk to us and explain about this. So, Michael, I'll hand over to you.
Thank you, David. I really am honoured and that I've been invited to talk to you all. I'll just introduce myself briefly because there's not much to introduce, but we're from Damascus, the Harari family, and they left Syria in the early 20th century for Egypt, and then in 1947 my parents were expelled from Egypt and found their way to Australia, where I was born. I've worked in a few parts of the world, mainly Papua New Guinea, Cambridge University, Addenbrookes, but most of my career as a paediatrician and all my training was at the Royal Children's Hospital, where I have a subspecialty in intensive care. But in the last 30 or more years, my professional passion has been child and adolescent incontinence. I made Aliyah finally about 10 years ago and have worked since then as a paediatrician in Ziv Hospital. About 3 years ago, I went down to part-time paediatrics so that I could study to become a tour guide. And I've been fortunate enough to pass the exams, and I now work half-time as a tour guide and half-time as a paediatrician. And my paediatrics is carried out there in the Ziv Medical Centre in Tzfat, which sits in the Upper Galilee. And the Upper Galilee, as I'm sure many of you know all too well, is really the Galilee panhandle, Etzbah HaGalil as it's called, the Golan Heights. And that's roughly the area. It's very close to Lebanon and a stone's throw away from my ancestral home in Damascus. And we're a university hospital attached to Ilan University. There are about 300,000 residents of the Upper Galilee and the Golan Heights, and Tzfat is by far the largest town in the Upper Galilee, which is where our hospital is based. The patients come from rural and smallish urban areas, and there are three main groups that live in the Upper Galilee. There are Druze, Arabs, and Jews in roughly equal proportion. And the population mix is very, very well reflected in the ranks of the medical and non-medical staff at our hospital in the so-called apartheid state of Israel, as the BBC might call us. The head of our hospital is a Druze person. The deputy head is a Muslim Arab. The heads of department in the medical field are roughly a third Druze, a third Arabs, and a third Jews. The cleaning staff are roughly a third, a third, a third. The patient mix is roughly a third, a third. And if that's what apartheid is like, then bring it on. I was asked to talk primarily about our approach to trauma and our experience with trauma, and using our experience with the Syrian wounded and the more recent Meiron wounded. And so I thought I'd start by just taking a step back from Ziv in particular and looking at Israel in general, how we're trained in Israel for assessing and treating trauma. And of course, medical school it's a topic that's much more emphasized here in Israel than in many other places of the world. But many doctors have served in the army, myself included. And if you're a combat doctor, you learn in your officer's course how to set up a mobile first aid station, how to set up a field hospital, and army medics and paramedics are sort of roped into the training. And they, myself included, I think, finish officer's course feeling highly trained in the first aid management of trauma and also chemical warfare, unfortunately. And it's drilled and drummed in and repeated over the 4 or 5 months of the officer's training course, and thereafter it's drilled and repeated during Miluim and ongoing service. It's not only the doctors, of course, that are well trained. The ambulance service is astonishing here. It boasts many medical students among the ambulance staff. Often students here work or moonlight in order to earn a living with the paramedical services in the ambulance. And so the ambulance service really is the backbone of the approach to trauma in Israel, and they're drilled and trained repeatedly as well. In hospitals, we have exposure to trauma, rare exposure to mass trauma, thankfully no exposure to chemical weapons, but nonetheless we practice, and every 6 to 12 months we go through an exercise with either mass trauma or chemical weapons, and sometimes both together. And so it's something that's reinforced repeatedly in the normal day-to-day life of virtually all hospital, medical and paramedical sort of staff. There has been a revolution in the philosophy of care in mass trauma. It's mainly devoted to the approach by paramedics to trauma, but the nub of it is the controversy between a philosophy that's playfully called scoop and run versus stay and play. Stay and play, the real name I think is Advanced Life Support in the Field, ALS, and underpinning it is the notion that you should give as much medical care as possible to casualties on site wherever the trauma happens. Stay and play is still the preferred approach amongst paramedics in Europe, and it obviously provides more comprehensive immediate medical care, but at the cost of delaying arrival at hospital. And on the other hand, there's the philosophy known as scoop and run, which is to offer basic life support in the field. And it's popular and was popularized in North America, and it allows a speedier delivery to hospital. And it's underpinned by a notion that you have to minimize any lengthy on-site care. The reason why it was adopted, I think, really, it came to the fore in the 1980s when comparative data was presented on survival rates in World War II wounded versus Korean wounded, where the transit time was an average of 5 hours between being wounded and getting to hospital, and the Vietnam War, where the transit time was about 1 hour. And every time the comparison was analysed statistically, the notion of scoop and run, in other words, very rapidly bringing the wounded person to hospital, scoop and run was more favourable than stay and play. And this despite the fact that the military technology over the years has become more dangerous, if you like, but the mortality with scoop and run has repeatedly shown itself to be less with wartime injuries. Then it was tested in the 1980s for general trauma, not just wartime trauma, and the same result was found, that scoop and run was found to have much better survival than stay and play. And the notion of platinum minutes or a golden hour was popularized in the 1980s, which reflects the idea that really you have a limited period of time to offer definitive care, and the better the definitive care is, the better the outcome, and that's probably best done in hospital. Limitations of scoop and run are, of course, that you can easily overwhelm the resources of a hospital as was seen in the Madrid train bombing in 2004, when there are 191 deaths and 2,000 people injured. And it's really unimaginable, really, how one hospital or one hospital system would cope with that level of mass trauma. But overall, it's very clear from scientific analysis of the dilemma that pre-hospital stabilization is an inferior concept to rapid transfer to hospital, unless, of course, it's unavoidable. I'll stop there with theory and then move on perhaps to why I suspect I've been honoured to be invited to speak to you, and that's to talk about two major areas of trauma, I guess, where Tzfat has played a central role. The first was the Syrians, and the other was the more recent tragedy at Mount Meiron. The Syrian civil war spanned from 2011 to 2018. In March 2011, the so-called Arab Spring of Syria, a term which I don't think anyone uses anymore, broke out in the southern Syrian city of Dera, when some teenagers daubed some anti-Assad slogans on a school wall, and they were arrested, and their parents were in turn arrested, and some of them were beaten up, and one father was killed. And that was the unique trigger for the Syrian version of the Arab Spring. 2 years later, in 2013, the United Nations pulled out because the carnage was too great and their workers were endangered. And so really everything we know about the Syrian civil war in terms of medical statistics comes not from within Syria, but from the Syrian Observatory for Human Rights, which, as you no doubt well know, is based in London. But over the 7 odd years of the Syrian civil war, it's estimated that about 500,000 people were killed. That's from a total population in Syria of about 18 or 19 million. There's a rule of thumb in war, which is for every person killed, another 3 or 4 or 5 people injured alongside them. So the UN estimate of 1.7 million people injured rings true. Perhaps uniquely, 70% of the medical community fled the country, and that's from the Syrian government-held areas. From the rebel-held areas, the medical infrastructure was totally decimated. The UN estimates that there are about 3.5 million external refugees and about 7 million internally displaced refugees. So from a population of 18 million, these figures are just staggering and difficult to digest and assimilate. It was extraordinarily difficult sitting very close to the Syrian border, hearing daily the tympanic sort of noises from the war in one's own backyard, in the tranquility of one's own backyard, and to be in phase 1, which is to do nothing. And it was almost with glee, with enthusiasm, with relief that on the 16th of February 2013, some 2 years after the outbreak of the Civil War, that we all got a page on our phones, all those who are involved in a mass trauma response at our hospital, saying, "Come into the hospital now, this is not a drill." And on that famous, if you like, infamous Saturday night, 7 severely wounded Syrians were brought by army ambulance to our hospital. And that was the start of what initially was told to us to be a one-off event, and then another trickle arrived the next day, and another trickle arrived the day after. And really what happened after all that was that some 5 years later, Israeli hospitals had taken in over 3,500 severely wounded people by and large. And in Ziv, we took roughly a third of those wounded. How did they get to us? Well, unlike the scoop and run notions that I touched on and we'll come back to a bit later, most of the initial care was done in Syria. Almost everyone who was brought to us had been operated on or had some temporary patch-up job in the 24 hours that it took them to get to us, from the time they were wounded until they got to us. there was no platinum minutes or golden hour. It was at least a day or more by the time they got to see us. And the reason they came to us, probably many reasons, but not the least of which was that if the rebels went and sought medical care in Damascus or in government-held areas, they were summarily put to death. And so it was a choice, a not very subtle choice of certain death against the unknown of coming to what was the Syria's declared enemy, Israel, which was geographically and politically much more convenient for them. When they crossed the border, initially what greeted them was a first aid station. But within about 3 days of the 16th of February 2013, that first aid station was transformed into a full-blown field hospital. And if you've never seen one, but you have seen an episode of MASH, you'll know that the 4077 looks very, very much like a real field hospital with generators and operating theatres, and they do an extraordinary amount of, or potentially can do an extraordinary amount of good work with very little resources. But towards the beginning of 2017, the field hospital was closed down because it was realised that it was much easier and much more in the patient's interest to really send everyone down to Israeli hospitals. And as I said, Tzfat took about 1/3 of them, but they also went to Harari and Rambam and occasionally to other hospitals. The Syrian casualties were primarily adult males, which suggests that they were fighters. About 70% of all casualties that came to us were children, and that's where I got involved. Nearly all people who got to see us, certainly all the children for the first few years, had blast or high energy injuries. And for those of you unfamiliar with the term, it's shorthand for complex multi-system injuries, which of course depend on your proximity to the blast. But with the inverse square law, the closer you are, the more likely you are to get hit in many different parts of your body. The complexity and severity of the wounds still to this day sort of takes my breath away, and I'm fairly battle hardened in the non-combat sense of, I've lived and worked in the third world for many years, and I'm an intensive care physician. I've seen road trauma and severe illness and death and destruction, but nothing had prepared me for this level of barbarism, I think, of war injuries are just shocking, and I certainly was unprepared for them. To illustrate their complexity, the Syrians took up less than 5% of our hospital beds, but say they took up more than 50% of our ICU beds. They had very prolonged inpatient stay. The average inpatient stay in our hospital is of the order of 1.9 days. The surgical ones maybe 2-point-something days. The Syrians stayed on average 20-point-something days. And they were a huge drain on resources, especially the nursing resources, who over the 5-year period often had to do double shifts and occasionally triple shifts just to keep up. And so it was a marathon rather than a sprint. But at the end of it all, I think we were all very proud of ourselves and felt we'd done a reasonably, should I say even more than reasonably good job. We admitted 180 children over the 5 years to our ward. Most had multi-system injuries, as I said. We had 12 with at least one amputated limb, 2 with a double amputation, 1 with a triple amputation. Particularly challenging were the children who came without families, the youngest being 4 months of age. And only slightly less difficult, and sometimes more difficult, was the severely wounded child who came with a severely wounded parent. And that was a shocking thing to behold. One of the very, very bright points in the care of the Syrians was the orthopedic surgeons. And I almost choke on saying this because it's rare that a physician looks to orthopedic surgeons with a benign or benevolent gaze. But the orthopedic surgeons, for all the jokes we make about them, they had an unusual philosophy, which was they were determined to save any limb that was classified as an incomplete amputation, meaning a limb that meets the criteria for being amputated, if you like. And without wanting to give you gory pictures, this I think is the only one, but limbs such as this are incomplete amputations that fulfill all the criteria for being amputated. And the orthopedic surgeons were devotees of what's called the Ilizarov technique, and used Ilizarov external fixation. I'll give you a physician's view of it, which means it has to be simple, not for your sakes, but for mine. The notion goes that if you have a bone that's broken at a bad angle, classical orthopedic surgery, as the name implies, is to straighten the bone, to realign it, and then you immobilize it, and then you hope for the best. Ilizarov, who was apparently a famous orthopedic surgeon, reasoned that in limbs that are threatened with amputation, in other words, the neurovascular supply is so severely compromised that it's easier to cut off the limb rather than try and preserve it. He said, if you try and straighten those bones with the best of intentions, what you're doing is creating further damage to a compromised neurovascular supply. And so his philosophy was that it was best to allow primary callus formation, leave the bone deformed without any further disruption or damage to the nerve and blood supply to the damaged limb, immobilize it with eventually a type of external fixation that he pioneered. And then it's got ratchets on it, which, and over time, once primary callus is formed, you then slowly tweak the ratchets, and so you can gradually over weeks straighten the deformed limb and realign it. And thus you can hopefully save a limb which otherwise would have had to be amputated. So our surgeons used Ilizarov fixation extensively, and a technique which is widely used around the world but is nonetheless new. So it wasn't around when I was a medical student 40-something years ago, which is vac drainage or vacuum assisted closure. And as the picture here illustrates, vacuum assisted closure is covering a very damaged part of a limb, say, with this cling film, this nylon, this plastic sort of covering. There's a hole in the plastic covering, and underneath the hole there's a sponge. Into the sponge drains all the hemoserous discharge from the wound, and the tube here is connected to perpetually connected to a pump that creates a vacuum, thus continuously sucking the hemoserous fluid from the wound through the sponge into a bottle alongside. And that's called vac treatment. And the combination of Ilizarov fixation and vac treatment, both were new to me, despite a background in trauma, but it was used extensively and with astonishing results. And again, I blush if I have to compliment an orthopedic surgeon on anything except his tie, but it was astonishing, the results that they achieved, and begrudgingly I ended up saluting and praising them. This is the same girl whose leg you saw here, walking out of the hospital 8 weeks later. She came back to us on 2 subsequent occasions, with her severely injured mother also coming back with her. This is another child's leg after already 5 or 6 weeks of vac drainage. There's the pump next to the bed that you can just see in the background, and also an Ilizarov fixation. Over the 5 years, we developed a very well structured, I think, philosophy of care, which centered on good nutrition. Some children, especially early on, came to us malnourished. I hadn't seen malnutrition since my years in Papua New Guinea in the 1980s. It became apparent how important it is to avoid pain. Perhaps for any child it is, but in a child who's had psychological trauma, if you inflict more physical pain on them, they won't recover from their psychological trauma. You'll only add to it. And so I, in my capacity as an intensivist, I guess, or past capacity as an intensivist, I administered ketamine sometimes on a daily basis to a string of children just for simple wound dressing, so as not to inflict any further pain on them. And we tried to normalize their lives as much as possible, which meant keeping a parent with the child, even if the parent was severely injured. And that may sound bleeding obvious in retrospect, but when they first came in with injured parents, we put the injured parent in the adult surgical ward and the injured child in the paediatric ward, because children have to be in paediatric wards. And then we were surprised when the child was mute and didn't eat and didn't want to come out under the blankets, until finally the parent was sort of brought into the room, and then suddenly the child's affect changed. It took us a while to realize that. It took us a while to realize the importance of schooling. None of the children who came to us had been to school since the outbreak of the Civil War. And it was astonishing the alacrity, the enthusiasm that they showed just to be given normal schooling. Similarly with play and play therapists, they were the easiest children to engage with the play therapists, even though not all play therapists spoke their language. And the stellar attraction really was the use of clowns. I mean, Australia pioneered the use of clowns already in the 1960s or early 70s. And I'd seen medical clowns at work, and for much of my working lifetime, I thought, well, it was a very nice way to have the little kiddies have fun or something. I really had never understood how important they can be in distracting children who are anxious and frightened and in pain. And what we did was we got the clowns in on our morning handover every day and sort of filled them in on what was about to happen to the child. And then the clowns would sort of bounce out of the handover room and start barking orders at the doctors. And many children, especially those about 7 or 8 years old, thought that it was the clowns that were actually running the show rather than us. And many children left hospital after weeks of being admitted, believing that the person pushing the wheelchair as they left the hospital was the one who'd orchestrated the whole show, which I think is a real feather in our cap. We had many, shall we say, ethical issues over the 5 years. The day-to-day ones were about informed consent. How do you give informed consent to someone who really has very little education and very little understanding of medicine and rudimentary physiology? And how do you explain complicated procedures to someone of that background? And even though you go through the motions, you still know that they haven't understood you, however simple you try and make it. And that was made further complicated by the uncertainty about our ability to follow them up. And lastly, certainly not least, was a fear that if we did complicated things such as the Elizarov treatments, that we would be seen as experimenting. And we were very fearful that with all our good intentions, that somehow it's not very difficult for people to give us a bad name. And we were very fearful that we would be seen as experimenting on children, all the while as we tried to save their limbs from having to be amputated. A late development really happened in 2016 when we started taking in not just wounded Syrians, but children with chronic illness. And I was given the honor of taking charge of that project. Interestingly, perhaps, were the simmering tensions that the wounded Syrians had with the Golan Druze, because there was most of the rebels came from the Jabhat al-Nusra persuasion, the al-Qaeda sort of branch in Syria. And the Jabhat al-Nusra often went hammer and tongs with the Druze in southern Syria. And so the Golan Druze had a sort of justified, perhaps, antipathy to the wounded who were coming across the border. And sadly, I think for many people in the southern provinces of Syria, Dera province and Quneitra province, in September 2018, the Syrian government forces retook the Golan Heights, squashed the rebels, and the civil war and our involvement, our medical involvement at least, came to an end. Normally I'd stop and ask for questions, but I think we will run out of time, and I believe there's time for some questions at the end. So with your approval, I'll move on to a different type of trauma, one which we found ourselves well prepared for, in part thanks to the Syrians, but by no means solely thanks to the Syrians. And that was on April 30th this year, at about 10 to 1 in the morning, the eve of Lag BaOmer. There was a crush in a crowd among the 100,000 people who attended the Lag BaOmer celebrations at Meiron, at Mount Meiron. And in the crush, about 45 men and boys were killed and about 150 people were injured. This is the deadliest civilian accident in Israel's history. And I think David was kind enough to ask me, well, how do you manage such a thing? Well, I was on call for the paediatric department on the night in question. And so I was called in at about 5 minutes to 1 on the same night. And as I was driving in, there was a police presence at every major intersection. Some were there already because Mount Meiron traffic has to be sort of guided in the right direction. Otherwise, Mount Meiron is swamped. But the police were obviously aware that something had happened. They told me on the way that a stadium had collapsed and there were hundreds of injured and dead. So by 5 minutes past 1, which is 15 minutes later, I was dressed and driving into Tzfat. I live about 10 minutes away from the hospital, and all roads to Tzfat were closed with police or civil guards only letting through important personnel, and I just waved my hospital tag and they waved me through. But alongside me and overtaking me were many ambulances that really came from all parts of the north of Israel. Within 15 minutes at the site at Meiron, some industrial lighting had been set up, and there were already many paramedical teams that were operating according to the scoop and run philosophy that we talked about briefly earlier. By about 1:15, I'd arrived in our trauma room, and our first patient arrived, who was a child, unfortunately about 11 or 12, who was dead on arrival. I'd had the rather surreal and sad spectacle of watching him having had his cardiopulmonary sort of massage because I was driving behind the ambulance in which this boy was trying to be resuscitated, and the light was on, so I had a sort of view from the back window. We were told as I walked through the front door that we were going to receive 150 injured people. And you can imagine that we're a small hospital. We serve a population of 300,000 people. How on earth are we going to manage 150 severely injured people? So I called in 3 senior registrars and the head of our department, but they were all an hour away. And I walked into the trauma room where we had a controlling doctor who had a loud commanding voice. He was an experienced surgeon in his 40s. And it was very, very clear that he was running the show. In our trauma room, we have 4 beds always set up, but we can accommodate up to 8. We have an adjacent, in the adjacent room, we have CT and X-ray facilities. But this controlling doctor said no one is going to CT and X-ray. And that was daunting. It sort of takes the wind out of yourselves. No CT, no X-ray. How on earth am I going to manage, forgetting that in Papua New Guinea, we'd managed, I at least had managed with much, much less than we had there available to us, and we got by just fine. But we're all somehow led to believe that we can't manage without new technology, and forgetting that we used to manage without it before it was available to us. But the reason for not sending anyone to CT and X-ray, it would just block up everything. The whole rapid turnover in the trauma room would be blocked up. And so we were told, use your clinical skills. We did have the benefit of an ultrasound technician. In about 2 minutes flat, an ultrasound technician can scan someone's liver and someone's spleen and see if they're bleeding, and probably look for blood in the peritoneal cavity. And so we did have some way of knowing if there was occult bleeding that we might have missed. And each bed was made into a team, and each team had an unofficial leader. So our bed, the one that I was put in charge of, had a paediatric registrar, an anaesthetic registrar, 2 nurses, and myself. And at about 30 minutes after the 10-to-1 accident tragedy at Meiron, we received our first patient. And it was astonishing that there was no shouting and no chaos. In Israel, everything is accompanied by shouting and chaos. And the boy we received was in mid-adolescence. He was intubated already and had a left intercostal catheter. And we knew nothing about him except that this was the boy, and we had no idea what had been done to him. But he had a tube in and someone was bagging the tube. And he had fixed dilated pupils, and he was tachycardic and had a very low, almost unrecordable blood pressure. And without the aid of x-rays, we did the basic things, which included trying to feel if the trachea was midline, like we all learnt as good medical students. And his trachea was markedly deviated to the right. And those of us who still remember that percussion is one of the basic skills, percussed and found his percussion was tympanic on the left side. So clearly his intercostal catheter wasn't working. So I incised and we put in another intercostal catheter with a very gratifying sort of puff of the release of pent-up pressure, and his trachea reverted to the midline. And in an enormously gratifying immediate improvement, his tachycardia dropped, his blood pressure rose, and within about 10 minutes, his unreacting pupils began to react. There was obviously some possibility that he had some cerebral trauma, and therefore the person who was controlling the whole thing came by our bed, wanted a quick update, and within 5 seconds decided that this child had to be flown to a place where there was a neurosurgical unit. So he was flown to Rambam Hospital in Haifa. Thankfully, we already heard the next day that he was fine, he was extubated, neurologically was normal, and with some justification, I think we felt pleased with ourselves both at the time, and then we were all very pleased with ourselves the next day when he heard how well he'd done. At about 90 minutes after the accident, I walked out to the front foyer, and there in the front foyer, it was clear that there'd been a general call-up of the hospital staff via an SMS message, because outside in the foyer of the emergency department stood a line of social workers and another line of nurses and another line of cleaning staff and another line of ward clerks, and all of them were looking slightly ruffled and uncoiffed and in their pajamas, some of them with coats draped over them, and everybody was a bit unkempt. And I hope I'm not being too rude to say that it reminded me of my walk 40-something years ago through the red light district of Amsterdam, having all these scantily clad women in pajamas all over the place. But everyone was quiet and everyone was waiting for direction, and it worked incredibly well, because the next cab off the rank, if we needed someone to put an identification bracelet on it, someone went to the head of the queue of the ward clerks and said, put an ID bracelet on this and record the particulars of the child or the adult. What was very gratifying to hear was that the Army helicopter unit was already in place, and they'd flown 2 people directly from Meiron to Jerusalem. And we were then told that even though there were about 150 injured patients, that the 5 general hospitals in the north of Israel were similarly geared to receive them. And so that in the end, we only received 35 out of the 150. And so what had happened was that the ambulance had, someone high up in the ambulance service had decided not to bring them all to the nearest hospital and overwhelm us, but in fact to triage and evacuate them more or less equally throughout the north of Israel. So they went to Nahariya, Rambam, both of which have neurosurgery, to Tzfat, which was the first trauma hospital available, and also to Poria in Tiberias and to Afula in the Jezreel Valley. The Army helicopter evacuation and transfer was rapid, and they came back quickly and kept on ferrying people from the site to different hospitals. And there was astonishing policing of roads and crowds. There were 100,000 people who'd been on Har Meiron within an hour were bundled into dozens and dozens of buses, which all the drivers were asleep waiting for the next day to take them home. But they were all woken up, and the crowds were dispersed very quickly. By about 4 hours after the event, everything somehow seemed settled and calm, and it was nighttime again, and the noise had gone, and the extra staff had started to go home, and virtually all injuries had been looked after, and all the transfers had been done. We'd admitted 5 children out of 35 people. 5 had been children to our ward, 1 to intensive care, and the other 4 to the general ward. 1 had been very pale and mute and tachycardic, and my clinical hunch was that we'd missed some bleeding somewhere in this child. So I went back about 4 or 5 times and saw him. The last time was with him sitting and talking to one of our social workers, and the penny finally dropped that this child was just stunned and was shocked rather than in clinical shock. It was also astonishing to realise that 4 hours had gone by and we'd all dealt with this. Everyone had been processed and had been treated, and scoop and run had worked well. And there was something tremendously uplifting about having the intensity of it all having been so productive, despite the fact that it was very clear that there was a major tragedy behind it all. So lastly, why did it all work so well? Well, it worked well, I think, because we practiced this. And I have a past as in improvised comedy. I used to appear in Jerusalem many, many years ago, and with a group of improvised comedians. We used to train how to improvise comedy. So you rehearse improvisation. This was rehearsed. We rehearsed how to improvise if needed, and paramedics rehearsed it, and hospitals rehearsed it, and in the army you rehearse it. And so it wasn't the first time for many, many people, certainly not for those who were at the upper end, upper echelons of managing this tragedy. It also worked well because I think many people have experienced the bus bombings of the 1990s, war casualties, going into Gaza. There is much first-hand experience from people who served in the army and in the ambulance service for this sort of thing. And there was astonishing coordination of available services, the ambulance, the police, the army, the roads were closed at the right time. And perhaps importantly was that the hospital has, over the last 5 or 6 years, been repeatedly trialling SMS notification. So about every 6 months, we get an SMS saying, this is a trial run. Please press 1 if you've received this message from the hospital. And so you press 1 and then you carry on with the rest of your day. But the hospital has tried, many hospitals have tried SMS notification, and the results have always been good. And although they've never tried it at 1 o'clock in the morning, but at 1 o'clock in the morning, SMS notification also worked. One thing we proved. We have decentralized hospitals in Israel, lots of small hospitals, even though you never have to travel. In Australia, you have to travel 1,000 kilometers to get to a regional hospital. Here, you really very seldom have to travel more than 10 or 15 minutes to get to another hospital. And decentralized small hospitals, especially with lots of empire builders in it, they usually punch above their weight. And I think we certainly did on that day. And last, scoop and run worked, as it has been shown in the literature to do. It worked astonishingly well. I would perhaps have put my last point as this was an affirmation about how we can all live together and work together and stuff. Unfortunately, I think I had to take it off my last slide because I'm so hurt by the world and what's happened in Israel in the last week or two that I can't drop my pessimism and dismay at the events around us, even though had I given this talk 2 or 3 weeks earlier, it would have been so upbeat and positive and optimistic about the future. I'll stop there and open the floor to questions.
Right. Well, thank you very much. I'm going to start off with a question about the contrast. The one you're talking about, blast injury and orthopedic injury. Was there any of orthopedic type injury in the Meiron episode as with children with their broken bones, broken limbs, or was this more like, if you like, crush injury?
It was certainly more like crush injury, but in crush injury, you also have broken bones in much the same way as in blast injury. You have broken bones and other injuries as well. But it seemed to be that you either died or you didn't. I know that sounds overly simplistic, but 45 people died, and they died on the spot because they couldn't breathe and they were asphyxiated and they were crushed to the point where they couldn't expand their chests. And if you survived that, whatever else you had, I think scoop and run made it all seem relatively manageable. So the people who came to us, the 35 or so that we got in Tzfat, we excluded the neurosurgical ones, and there were about 3 or 4 severe brain injuries from the actual trauma. But all the other injuries we had were relatively manageable. There was someone who had a lacerated liver that was managed conservatively, and that just went fine. 2 children in our ward with broken bones and nothing else. Most of the 150 who survived, most of them were discharged the following day or 2 days later. So it seems that you either died or didn't. And if you didn't, then, the injuries were relatively mild. I don't want to diminish them in the eyes of those who suffered from them, but certainly in the standing back and the overall look at them, we didn't see anything that resembled major trauma. We didn't see much of what resembled the major trauma that war injuries have inflicted on the people that we've seen from Syria.
Obviously, with my background, what happened, those who died, they were identified as dead by whom, and what happened to them? Where did they go?
Most of them were not identifiable immediately. They all went to Abu Kabir, which is the pathology center in the center of the country, and very traumatic, but they all had DNA identification from relatives before their identity was confirmed. So in Abu Kabir, DNA was taken from every single one.
But some of them were identified as dead on the spot by the paramedics. Who was doing the identification at the
I don't know. In Israel, there's a tendency to only confirm death if you've been trained or accredited as someone. So someone like myself, the hospital appoints a string of people who are accredited to certify death. So I certified the death of the 11 or 12-year-old boy who came to us. I don't know in the field who decided, but I'm sure it was decided on the spot that some people should not be resuscitated because it was a waste of precious time. But I don't know who made that decision.
And the other thing about the Meiron is that presumably what actually happened, it's the equivalent in the UK was the Hillsborough, or it seems that the equivalent was the Hillsborough disaster at a football match.
Yeah.
Is there any investigation of the actual procedures that were used and preventive measures taken? Because you're prepared for the disaster, but are you prepared to?
I'll say you're very much outside any area of my expertise, because there is an investigation, but like so much in Israel, it's clouded by political infighting. I think no one wants to be left carrying the blame for this major civilian tragedy, and the police are the ones that feel that they're going to be left holding it, whereas in fact they were pressured to allow the thing to go on, even though the health department said one thing and something else. And so it's likely that there'll be from a prime ministerial level, if we can ever appoint a prime minister, it's going to be not at the level of the police or the health ministry or any minister or any individual ministry, but rather one step higher up. They're going to appoint an investigation committee to try and apportion blame, but hopefully to try and make sure that something like this does not happen again.
There's a two-part question. Part of it asked by Andrew Surzensko. Have you had any contact with any of the Syrians? Number one.
Question. Go on. Would you?
And the second part of that is what is being, you discharge patients. What is being done with the follow-up of those patients? Follow-up of the children that have been through this traumatic experience and ended up in your hospital, or have they been referred to there?
I have to hijack the question somewhat and just point out how close and how warm, and I don't want to use too many cliches, but how loving their relationship is with the children who came and spent months with us and had breakfast with us and had, did ward rounds with us and really became part of the family of Ziv Hospital. And seeing them leave, first of all, was very sad for us, partly because it's like we're not going to see them again, and partly because of what they were going back to. And therein lies some of the answer to the question. It was dangerous, I think, to keep contact with them. While the rebels were holding sway in the two provinces adjacent to Israel, there were close contacts at many levels, but once the Syrian government took over, any contact that is continued with people within Syria is life-threatening. And so very little contact has been made. During the 5 years until September 2018, when Assad retook the two provinces, it became easier and easier over time to arrange elective readmission from Syria. In other words, the ties between the Israeli army and various authorities among the rebel forces, the ties became closer and closer over the years, to the point where you could discharge someone and say, I want them back in 6 weeks in order to change their external fixation or to finish the staged operation on their leg or this, and that became quite common. All that evaporated in September 2018 when the Syrian government forces overtook the rebel provinces to the south. Similarly, the project that I was given, which was to every fortnight to have about 25 Syrian children with chronic illness cross the border and be triaged and see what can be done for them, it was very easy to arrange for them to come back on a certain date and finish whatever investigation was required. That dried up. And to keep contact with them is regarded as too dangerous. Having said that, there is one person in the hospital, an Arab from Nazareth, who keeps contact with 2 or 3 of them through WhatsApp, and I shouldn't tell you his phone is rerouted through this and that. So there is one person from our department who has maintained contact with some of the long stayers. And so we do get occasional feedback about their welfare. I should say that it was reported to us quite early on that the father of one of the children who spent a long time in our ward was killed as a collaborator solely because he'd spent time with us. And so we were very, very careful how we discharged them. They were discharged with letters in English or Arabic and not in Hebrew and not on hospital letterhead. And it was a very fraught thing, their return to Syria, and it would be endangering them to try and keep contact. I would love to with some of them.
And what about the current cohort? Are they being referred to their local health services in any kind of way, the ones that have been...
There are no more, from September 2018, there are no more Syrians that crossed the border. We were left with one patient that sort of went beyond September, stayed with us into January 2019, and he was eventually returned to Syria through the intercession of the International Red Cross.
Yeah, I mean the Meiron kid, the Meiron.
Oh, forgive
children.
me. Ask me again. Could you ask the question again, David? I'm sorry.
I'm just asking about the Meiron children. Is there
Meiron
any
children,
follow?
by and large, left hospital very quickly, as I said. Those that survived. And so we haven't had any follow-up from them. Their injuries were ultimately, mostly, not all of them, but mostly were on the minor scale of things. The psychological trauma was enormous, and that was addressed both in the hospital, but also ongoing services in the community have been very, very busy following up not just the children, but also the adults. There were a couple of families where several members of the family died together. And
There's a question about the Syrians, about the question of John Grabner is asking about the use of hyperbaric oxygen. Was that tried at all or used at all?
Not that I know of, not for our crash injuries, not as far as I know, John.
Right. I mean, there's one question which you may not wish to answer, but the question is, how have the present troubles in post the April 30th impacted on the medical services in Tzfat?
I felt a little betrayed, I think, by the events within Israel. And I think many people, even those with an opposing stance to mine, feel betrayed by the same token. So yes, there was, I think we were all more careful with one another, and paradoxically perhaps, because we were treading on one another's eggshells, I think we became kinder and more polite to one another. So in an overt sense, nothing has changed, but I sense that everyone's a bit more careful with one another because it was such a charged atmosphere outside of the hospital. I think we were well supported. The hospital, the CEO of the hospital, the head of the hospital sent a letter out in Arabic and Hebrew, talking about the family of Ziv, the height of their trouble. And I think he struck the right note, and many people, Arabs, Druze, Jews, felt that he spoke directly to them and in a sincere way, which was very helpful. But I would be deluding myself and you if I were to say that it was business as usual. It wasn't. But I think we've been very careful to with one another so that hopefully business will be as usual again in the future, and hopefully in the near future. It's not naive. I think there is a basis to believing that.
There is a question which has come to the fore in the UK in the last couple of weeks. I know that the medical school has a mixed ethnic religious background of medical students.
Yeah.
Are the medical students, are they actually coping amongst themselves? Are there any tensions that have been noticed amongst the medical students? Because they're younger people, and it's a discussion that I've had.
All valid questions, and obviously so many individuals that it's very hard to give a definitive answer, micro answer, but I'll give a macro answer, which is that in general, the Israeli medical system is an oasis of sanity in amongst the wild west of the Middle East, and so much hate and tension and bigotry. Sinat chinam in Hebrew is the expression. But I think the medical establishment has always been above that. And for example, on the night of Meiron, these were all, ultra-Orthodox people, but the people from Muslim and Christian Arab communities and Druze communities came out as one. There was no difference in how we all pulled our weight. And as someone who's been in the medical system in Israel on and off for 40 years, even though I only finally made Aliyah 10 years ago, but years in Hadassah, which was much more tense at times. the medical establishment has always been careful to keep the politics outside of the hospital, and it's been very successful in that. And if one wants to look at a model or an oasis, if you like, of what the future might look like or what we might aspire to, even now the Israeli medical system provides such a view, including the medical students. You know, it's not, and again, I'm not giving you a saccharine sort of feel-good message. It's, I really think the medical system in Israel has been careful and has found the right sort of, in a very sort of difficult environment, has found the goat trail that sort of wanders through the minefield.
Right. Well, of course, that brings us to your other pastime, which is the goats.
Goats. Now I can start talking. Now you've got to cut me off.
And
goats. I have three female goats given birth about 3 or 4 months ago. So we have 7 kids, as it were. And yeah, we milk our goats and make cheese. I've got a neighbour who lives above me, he's an old friend, and we have a small dairy farm for domestic use.
Right. Okay.
One
So
of my interests.
And that probably provides you with the kind of relaxation that is necessary to maintain the kind of continuity and optimism and effort that you've shown us so wonderfully in what you've said to us tonight. Effort on behalf of patients both from Israel and from Syria, efforts on behalf of the children of the north of Israel, and efforts on behalf of the goats. So I'd really like to thank you very much for spending the time with us. And I know it's after 11 o'clock in Israel, so I think we'll say good night.
Thank you very much, David, and to all of you for listening.